My name is Rashmi Halker Singh, and I'm the Deputy Editor of the Headache Journal. It is my pleasure to be joined today by one of my good friends and colleagues, Dr. Angeliki Vgontzas, who is one of the authors of a very important perspectives piece entitled Addressing Inequities in Headache Care by Embedding Services in a Community Health Center in Boston, Massachusetts. Welcome, Dr. Vgontzas.
Thanks so much for having me.
I'm really excited to talk to you about your work. To begin with, can you share about your project a little bit?
Sure, of course. So what we've done is we've actually embedded a neurology clinic within a community health center, which is affiliated with the hospital I work at, which is Brigham and Women's Hospital, which is one of the Harvard affiliate hospitals. Many of you might know the Graham Headache Center, where I also work at, which is a tertiary headache center. And that's located actually just a few miles down the road from one of our community health centers. Now, community health centers exist all over the United States. They were started here in Boston, actually, and they were intended to really meet the needs of people who were more vulnerable in communities that were poor and communities of color, as well as in rural communities, so both urban and rural communities. So the two that are affiliated with our hospital are located in areas of Boston that were historically redlined and faced systemic racism. And they continue to treat a high proportion of patients who are affected by barriers from systemic racism as well as poverty. The community health centers are a little bit different than a regular, let's say, internal medicine office that might be a private practice, in that they also get resources to address social determinants of health. Things like housing or food insecurity or transportation difficulties. So there's a whole team of social workers and community health workers, people who work on food access, housing, working with the Boston Housing Authority in addressing those needs for the patients. The community health center that I had approached had an internal medicine clinic, pediatrics, OBGYN, and they actually had embedded behavioral health services. And I asked them, how often are you referring to a neurologist? And this was specifically the internal medicine doctors, because I'm an adult neurologist. And they ran their data and they said, well, we're referring at least 30 patients a month to neurology. And our impression is that, a good proportion of those consults actually aren't completed. And when we looked at the data later on, we saw that actually only 30% of the patients they referred completed a neurology consult. And so I said, how would you feel about embedding a neurology clinic here? And they said, that would be awesome, because that would overcome all of these systemic barriers to getting to the other outpatient neurology clinics. And then, so they were very excited about that. And that was kind of the first step. And then I asked them, what do you see? They said, well, we see a lot of headache. That's, probably half of the things that we're referring to neurology. We have experience treating headache. But when it gets more complicated, when it gets to chronic migraine, cluster headache, other more unusual headache types, we really need neurologists' help. And so about half of the patients they see for neurologic reasons are headache patients. Then I talked to my department and I said, it seems like there's this need in the community, patients who are having difficulty overcoming some barriers and getting to our clinics. How would you feel if I moved a couple of my sessions over there? And they were actually very excited about this. Now, this was about 2 years ago. It was in the midst of the pandemic, and also in the midst of the Black Lives Matter movement protests after the murder of George Floyd. And at that time, a lot of healthcare systems, including mine, were examining how they could improve access for patients who had faced systemic racism. So we had a system-wide initiative called United Against Racism, and they actually were asking each department to enact projects that would have sort of immediate outcomes, not just studying, disparities, but also kind of acting on the local community. So that kind of environment helped, and I approached my chair, and he kind of opened it up to all the vice chairs in the department, and they all agreed that that would be a good initiative for us. So that's how the clinic got started. And the financial model was really that the Department of Medicine bought out 2 of my clinic sessions. So I didn't have any change in compensation. I didn't have any additional clinical load. And that's sort of the beginning.
What an incredible story. So you've been going 2 days a week, 2 full days a week since then?
So 2 clinic sessions, so
2 clinic
1 day a
sessions.
week.
Okay.
But then after the first year, the sessions were actually like I was starting to double book, and we ran the numbers at the community health center, and we were able to add an additional session as well.
Amazing. So when
Yeah.
you're there, you see a lot of people who have headache problems, but I'm assuming it's also a general neurology clinic too, right? People, you said about half of the people have a chief complaint of some kind of headache problem, but are you also the person that they'll see for other neurologic problems as well, or do you have other colleagues who go down with you?
So it's just me on the attending level right now. I was also prior to this seeing patients for, general neurology clinics. And so for me, it was a continuation of what I was
Perfect.
doing. I have a sense though, that even if I would only want to do headache, there would be enough to do
Okay.
at least a session or maybe even 2 a week there. But we see a lot of patients who also have memory complaints, dementia, movement disorders, peripheral neuromuscular complaints, all sorts of things that you see bread and butter, and some that are patients who probably should have seen a neurologist a long time ago and haven't. So sometimes we see kind of unusual delayed presentations of other rare disorders.
You mentioned in your piece that this has been a continuity clinic location for a couple of your residents as well. I thought that was really amazing. I'm the headache fellowship program director for our site in Arizona, and we talk a lot about diversifying patient experience for our trainees as well. What have your residents said about what their experience?
Yeah, so that was a suggestion from my chair, and we thought about it very carefully because we I really wanted this to be, equal quality with what's offered at the main Brigham. I didn't want to sort of like drop in. So we decided that we would have, and this was basically what I could handle, 2 residents that would choose this as a continuity clinic site. Now, the residents who have come through, there have been 3 so far. The first, Jillian Berkman, was, a great advocate for racial and social justice. She wrote a piece in JAMA Neurology on carotid physiology and chokeholds. So she kind of like her name came up. We sort of like found each other, and then we have 2 more. The second one is an MD PhD who's going into neuromuscular, and the third one is now PGY3 who has expressed an interest in headache. And part of it, I think, is due to this experience that we've had. All 3 of the residents have actually really enjoyed the fact that we have so much one-on-one time with a headache specialist, because in their regular continuity clinics, it's sort of like hit or miss who the subspecialist will be who's precepting. Not that everyone has to be headache trained, but at that, because so much of their training is inpatient, I think they're really just thirsty for learning all these techniques that we have, and secondary and tertiary kind of medication options for our headache patients. So a lot of what we focused on is headache management, actually outpatient headache management. Other things come up, like because we're physically located in that internal medicine practice, a lot of times I can just walk down the hall and get more of a history, or just consult with the patient's primary care provider, or even the social worker, which has been really important, especially when there have been situations of significant trauma or anxiety, depression, things that might not be as open in the first visit. So we've been able to kind of have this very nice and open communication. And I think, one other advantage is that, at least for our residents, their continuity clinic tends to have a lot of hospital follow-ups, patients who've already been on the neurology service and had workups. And so that tends to be less of an educational experience, I think, than patients who have never seen a neurologist, like this patient population. And the residents have been awesome. I mean, they've taken full ownership. They've gone above and beyond, connecting with the primary care doctors, connecting with the social workers, the counselors, and it's been a great experience for all of us, I think.
That's really great. We always think about the next generation and the pipeline and neurology, and it's really, I think, important to hear this feedback. Dr. Vagantis, this is an incredible endeavor that you've put together, both in terms of patient care and access and education. And I can't help but think that when you do something of such significance for your community, it can't help but impact you as well. And I was just curious if you've had a chance to kind of reflect on that and if there's anything you want to share with us.
Yeah, absolutely. I mean, the drive for this clinic was a need to connect more deeply with the my neighbors, essentially, and my neighbors who are underserved. And although, you know, I'm one person, I had so many conversations and mentors. Dr. Elizabeth Loader, who's been my mentor ever since I was a headache fellow here, has been a great inspiration. I mean, she's done, national studies which show the healthcare disparities in patients who are non-white and patients who are poor. And so we were able to kind of draw upon what we know from national trends on the local level. She was also familiar with this community health center, having done lectures there and seen many of their patients in the past. Several other of the physicians I work with, both in headache and in general neurology, and I had many conversations around the time of the pandemic. And that was also the time we were exploring virtual visits for the first time. And one of the attendings I work with, actually, he realized he was doing a phone visit with someone who lived like 2 doors down from him. So he went and like examined him on his porch. So there were a lot of like creative ideas coming out at that time. And so, I had that drive. Now that I've been there, I think it's been for me, as in other settings that I've worked in and underserved, very like inspiring, actually, humbling in some ways. And it also makes me want to be a better diagnostician and a better neurologist as well, because, as you can imagine, some of the patients have more comorbidities or medical comorbidities. Some have delayed presentations. Some are, finally establishing care as a neurologist after like decades of having chronic migraine and things like that. So for me, it's been a great learning experience. I have a lot of fun, to be totally honest. I have a lot of fun, and it's a joy to be there.
Wonderful. Well, thank you for the great work you've been doing. I mean, you're an inspiration to all of us, and I'm sure that people are watching are inspired to do more as well. So thank you for that.
Yeah, absolutely. And if anyone wants to talk about the model that we've created in more in detail, I'm happy to talk with people and encourage them to reach out to their local community and just kind of get the conversation rolling. I think once you start talking to the right people, you start to get ideas and figure out where the opportunities are. So that's what happened with us. So I hope, people can reach out to their own communities and colleagues and figure out what works best for where they work.
Wonderful. Well, thank you so much for having this conversation with me today, and thank you for all the great work you're doing.
Great. Thanks so much. Have a great day.